Hello, my name is Morgan Willoughby. For my focused health assessment case presentation, I will be discussing a lateral ankle sprain. I will review the patient's presentation and then focus specifically on the assessment techniques and clinical findings used to evaluate an acute lateral ankle injury. The patient is a 30-year-old male presenting with right ankle pain and swelling after an injury while playing basketball the previous night. His chief concern is the pain and swelling associated with rolling his ankle. The injury occurred last night while the patient was playing basketball. After jumping for a rebound, he landed on another player's foot and his right ankle rolled inward. He reports hearing a pop followed by immediate pain. He was able to limp off the court but could not continue playing. Overnight, his swelling and stiffness increased. This morning, he has difficulty bearing weight and describes a feeling of instability while walking. His pain is sharp, with movement and aching at rest, rating it a 7 out of 10. This inversion mechanism is particularly important because it commonly places stress on the lateral ankle ligament complex. The patient has no chronic medical conditions and has never previously injured his ankle. He takes no daily medications and has no drug allergies. For the current injury, he applied ice once last night but has not taken any medication. His lack of previous ankle injury is relevant because recurrent sprains can result in chronic ligament instability and can alter the interpretation of the physical examination. The patient participates in recreational basketball, which is directly relevant to his current injury. He denies tobacco and illicit drug use and reports occasional alcohol consumption. His occupation is not provided in the scenario, so additional questioning would be needed to determine whether his injury could interfere with occupational demands, particularly if his job requires prolonged standing, walking, climbing, or lifting. For the focused review of systems, I would prioritize the musculoskeletal, neurologic, skin, and constitutional systems. Within the musculoskeletal system, I would ask about pain location and severity, swelling, stiffness, ability to bear weight, instability, decreased movement, and pain in adjacent joints. Our patient reports right ankle pain rated 7 out of 10, swelling, stiffness, instability, and difficulty bearing weight. He denies knee or foot pain. These findings help localize the injury to the ankle. A neurologic review is important because nerve involvement can produce numbness, tingling, or weakness. This patient denies all three, which is reassuring and is consistent with his intact distal neurological examination. For the skin, I would ask about wounds, bleeding, bruising, and skin changes because traumatic injuries can involve soft tissue or an open fracture. He denies open wounds and visible deformity. I would also screen for systemic symptoms such as fever or chills. Although these would not be expected with an uncomplicated traumatic ankle sprain, their presence could suggest an alternative inflammatory and infectious process. The patient's blood pressure is 122/76, heart rate 80, respiratory rate 16, temperature 98.3 degrees Fahrenheit, and oxygen saturation 99% on room air. His vital signs are within expected limits, and he is afebrile and hemodynamically stable. No systemic abnormality is apparent from his vital signs. The physical examination begins with inspection and comparison of the injured ankle with the unaffected side. I would assess gait if the patient can barely safely bear weight and inspect for swelling, ecchymosis, deformity, and overall alignment. In this case, moderate swelling and ecchymosis are present over the lateral malleolus and lateral ligament complex. Next, I would systemically palpate the ankle, including the lateral malleolus and lateral ligament complex, while also assessing relevant bony landmarks for tenderness that could suggest fracture. Our patient has tenderness over the lateral malleolus and lateral ligament complex. Active range of motion should be assessed first, followed carefully by passive range of motion as tolerated. This includes dorsiflexion, plantar flexion, inversion, and eversion. Both active and passive range of motion are decreased in this patient because of pain. Finally, a distal neurovascular examination is essential following an extremity injury. I would assess pedal pulses, capillary refill, skin temperature and color, distal sensation, and motor function. His pedal pulses are 2 plus and symmetric, and distal sensation is intact, which is reassuring for preserved distal neurovascular function. Special maneuvers help determine which structures are injured and identify conditions that may mimic a lateral ankle sprain. The anterior drawer test assesses primarily the anterior talofibular ligament. The heel is stabilized while the examiner draws the foot anteriorly relative to the tibia, assessing pain, laxity, and the quality of the endpoint. In our patient, anterior drawer testing produces pain but no gross instability. The Talar tilt test evaluates lateral ligament stability, particularly the calcaneofibular ligament. I would also consider the squeeze and external rotation test when a syndesmotic or high ankle sprain is suspected. Because the patient reports hearing a pop during an athletic injury, assessment of the Achilles tendon is also important. The Thompson test can be used for screening for Achilles tendon rupture. Equipment for this focused assessment may include an exam table, a goniometer to objectively measure range of motion, and tape measure to compare swelling. An ankle brace or crutches may also be needed depending on his ability to safely bear weight. A right ankle x-ray was obtained and demonstrates no acute fracture or dislocation. This is an important finding because fracture is a major differential diagnosis following an acute ankle injury. In clinical practice, the Ottawa ankle rules can help determine which acute ankle injuries require radiography. The assessment includes specific areas of malleolar bony tenderness and the patient's ability to bear weight and ambulate. Our scenario reports difficulty bearing weight and lateral malleolar tenderness, although it does not provide enough detail to determine whether every specific Ottawa criterion was met. Therefore, I would document those criteria specifically during the assessment. In this case, the negative radiograph combined with the mechanism and soft tissue exam supports a ligamentous ankle injury rather than an acute fracture. Although the assigned diagnosis is a lateral ankle sprain, several important alternative diagnoses should be considered. First is an ankle fracture. Acute pain, swelling, malleolar tenderness, and impaired weight bearing make fracture important to exclude. However, his x-ray demonstrates no fracture, making this diagnosis less likely. Second is a syndesmotic or high ankle sprain. These injuries can also occur with traumatic ankle mechanisms and produce significant pain with weight bearing. Specific syndesmotic testing and the location of tenderness help distinguish this from a lateral ligament injury. Third is an Achilles tendon rupture. The patient's report of a pop during an athletic injury makes this an important consideration. However, his pain, swelling, ecchymosis, and tenderness are localized to the lateral ankle rather than the posterior Achilles region, making this less consistent with the overall presentation. The primary diagnosis is a right lateral ankle sprain. The mechanism strongly supports this diagnosis because the patient's ankles rolled inward after landing on another player's foot. His subsequent lateral ankle pain, swelling, ecchymosis, and tenderness over the lateral ligament complex further supports injury to the lateral ankle ligaments. Pain with anterior drawer testing provides additional evidence of lateral ligament involvement. He also has decreased range of motion and difficulty bearing weight due to the pain. Importantly, distal sensation and pulses remain intact, and radiographs show no acute fracture or dislocation. Taken together, the mechanism, history, physical exam, and imaging are most consistent with an acute lateral ankle sprain. That integrates essentially all of the diagnostic evidence. No additional immediate imaging is necessary based on the currently provided negative radiograph and reassuring neurovascular examination. The patient should be reassessed as the acute pain and swelling improve, including range of motion, ability to bear weight, gait, ligament stability, and neurovascular status. If symptoms fail to improve as expected or significant pain or instability persist, additional evaluation may be necessary. Advanced imaging such as MRI can be considered when there is a concern for an occult or associated soft tissue injury, and referral to sports medicine or orthopedics may be appropriate. For pain management, acetaminophen 650 milligrams orally every 6 hours as needed is one option, with attention to the max daily dose and avoidance of duplicate acetaminophen containing products. Alternatively, if the patient has no contraindications, ibuprofen 400 milligrams orally every 6 to 8 hours as needed can be considered for short term pain control. Before recommending an NSAID, I would assess for renal disease, GI bleeds, or ulcer history, anticoagulant use, medication interactions, and other contraindications. Opioid pain medication is not indicated based on this uncomplicated presentation. Patient education should emphasize protection of the ankle while avoiding unnecessary prolonged inactivity. An appropriate ankle brace or support can protect the injured ligaments. Ice can be applied for approximately 15 to 20 minutes at a time, and compression and elevation can help manage the swelling. Weight bearing should progress as tolerated, with crutches used temporarily if needed for safe ambulation. As pain permits, gentle range of motion exercises can begin and later progress to strengthening and balance training. I would instruct the patient to seek prompt reevaluation for worsening pain or swelling, new numbness or weakness, changes in the color or temperature of the foot, or other signs of neurovascular. This patient is appropriate for outpatient management because he is hemodynamically stable, has intact distal sensation and pulses, no gross instability, and no fracture or dislocation on imaging. I would recommend follow-up in approximately 1 week to reassess pain, swelling, gait, ability to bear weight, range of motion, ligament stability, and neurovascular status. Earlier evaluation would be necessary for worsening symptoms, persistent inability to bear weight, new neurologic or vascular symptoms, or other concerning changes. An important long-term goal is preventing recurrent ankle injury. Rehabilitation should include progressive strengthening and balance or exercises after the acute symptoms improve. The patient should restore functional range of motion, strength, balance, and confidence before returning fully to basketball. Appropriate footwear and, when indicated, ankle bracing or taping during higher risk activity may also reduce re-injury risk. Return to sports should be based on functional recovery rather than simply the number of days since the injury. This concludes my focused health assessment presentation on lateral ankle sprain. Thank you.